you all to this, the March board of the George Eliot. Equally delighted to welcome friends from CQC who are joining us today. Just so you know, on a board day we have a morning board workshop. This morning we had an update from Daniel Oom, the chair of ICS, on the Health and Care Partnership. We had our 6 monthly update on health inequalities, a really fantastic presentation there from Duncan Vernon, our consultant in public health, and Yasser Din and Gemma McKinnon. We then talked about our green plan, which we'll come back to a bit later, had our quarterly people update, and did a deep dive into issues we've been having with some of the shared service level agreements with tertiary partners. So we had a chat about those as well. So a really full morning, but delighted to now be back with you all for this board. So first of all, are there any new declarations of interest of which we should all be aware? Could you please raise a digital hand? Can't see any digital. Sorry, Julie.
Yes, I've been appointed to the Staffordshire and Stoke-on-Trent ICB as designate audit chair.
Fantastic, Julie. Absolutely delighted for you, and thank you for all the work you do to help our citizens generally. Any others? Or forever hold your peace. Okie dokie, so the last set of minutes held on the 1st of February, was everyone happy with the accuracy of those minutes? If you weren't, please raise a digital hand. Can't see any digital hands being raised, so I'll take those as accurate. So we then go to page 17 of the pack to go through the matters arising. The first was the Dowgit to provide a more detailed analysis in regard to birth rate demographics. We'll come back to that next month. That's correct, isn't it, Dowgit? Thank you. And then David to bring back a detailed report on the trust discharge position on the 5th of April. That's for next month. Dowgit again to bring back a full report that reflected gaps and mitigations in place against the CNST standards. That's for next month as well. And then Dowgit to provide a progress update on electronic wall dashboards. That's for next month, I think, as well. Dowgit, you're looking a little bit perplexed at that.
Yes, I am, aren't I? So the update there is, I didn't think we wanted a detailed report on this, but I can give you a further update to say that the work had been put on hold due to capacity issues in the team. But this week we've picked that up again and we're making progress on that. OK, give us another update next month, please, Dowgit. That's great. Then on Glenn's report, a slight change in the minutes, and that was done. Thank you, Miss. Then a few carried forward again, which are coming up later on in the year. Sarah to notify Trust Board on changes to board meeting dates. Come back to that at the start of April. Proposed updates to the maternity service risk management strategy. That's due back in June after being through the audit committee. And then a clearer picture regarding the level of maternity incentive scheme, clinical negligence scheme for trust compliance. That's coming back next month, Dowgit. Yeah, sorry, Chair. I just to point out that that's a repeat of the previous action on CNST. OK, fine. Thank you. Let's make sure we take one of those out, please, Ness. And then conversion data on applicants offered opposed to George Eliot versus those who subsequently accepted to be included in next month's safety nursing and midwifery staffing report. That's happening in April. Great. It's going to be a busy month for you in April, Dowgit. Always is, Chair. Then Jenny to liaise with Optum's programme lead at system level about presenting a case study to board workshop regarding population health management. I'm going to come back to that, but obviously with the session we had on equalities, we're doing quite a lot with Duncan anyway, Jenny. So if we can clarify that date
as soon as possible, that would be good. And then a deep dive into shared service delays I referred to earlier, that occurred this morning. Have there been any matters arising that I've missed off that comprehensive list? Please raise a digital hand. Okay, then we'll canter into Glenn's report. Glenn, how are you seeing things, please?
Thank you, Russell. So just a few things to highlight this month. I mean, firstly, the delivery plan for tackling the COVID-19 backlog of elective care, which is also referred to as the elective recovery plan, is something that has been probably the most significant thing that's come out nationally over the last month. And it's a good plan, and it includes a lot of transformational change, including particularly a lot of change to the way we deliver outpatients. By moving to more patient-initiated follow-ups, by using technology, and therefore turning some of that capacity that those innovations create into seeing more patients and reducing the backlog. Obviously, the backlog has got into a challenging position nationally, and we've been given significant additional funding, which is outlined here. And so this plan sets out how over the next 3 years the NHS is going to work collaboratively with primary care, particularly, to address this. I think it's fair to say that we are already in a really strong place locally. We are still, though, at a national level 4 incident with COVID. And so one of the things that we will be keen to see over the coming weeks is hopefully a step down from that level 4 and a return to some of the more kind of localized decisions around things like infection prevention and control. We still have some guidelines that were founded in some of the earlier waves of COVID that probably need reflection, particularly if COVID continues to be the mild form that we're experiencing at the moment. But we can't lose our focus on quality and safety. But there's an awful lot of patients across the country who are waiting for surgery, and we've got a real responsibility to ensure that they're treated quickly. So locally, in response to that, we've been over the last couple of weeks looking at the capital that's been made available, and that's been made available at each region to look at solutions for how we can create more capacity. I mean, I think one of the things I would say before we get into what we can do to create elective capacity is one of the big things that we can do is manage urgent care. And that's very much been our approach locally to ensure that our urgent care activity is as quick and as effective as it can be, and that we don't spill over into our elective capacity and cancel elective work. So I'm referring to Operation Ring Fence across the group as something that we're going to be ensuring that we protect those elective beds so that we can ensure that their surgeries take place. We, because that relatively strong position that we're in at both George Eliot and Swift, it's less so at Wye Valley, we will be looking at how we can help others. So mutual aid is very much part of the national plan. So we've put forward some proposals against that regional capital allocation that would increase our theatre capacity. And we've been looking at the Leicester population, where waiting times are much longer than they are for us, and are offering help to our colleagues in Leicester. And we'll see whether that's something that we do. I think, though, increasingly, patients who are waiting a long time, we will need to help to encourage them to take up offers of treatment that may be slightly further afield than normal. And we need to support them to do that and not introduce new inequalities. I'll then talk about the annual staff survey, and it's embargoed, so I can't talk about it, particularly with a colleague from the CQC on listening to this meeting. But in very much headlines, and this will be out at the end of the month, we've moved to a stronger position as an organisation. And elsewhere in the group, we've moved to stronger positions also. So this is the most important indicator that crosses my desk every year, and you'll hear me say that every year. Understanding what our staff feel about our safety culture, whether they'd recommend us for care, whether they'd recommend us as an employer, is such an important test that I was really pleased to see those results, and we'll celebrate those when they're more publicly available. But of course, even with the best set of results, there are areas where we can do better, and that will feature as part of our objectives that we're discussing later. There's then an update from the Urgent Emergency Care Directorate with lots of great stuff going on there. Good performance against the 4-hour standard in context with what's been a really tricky period. Doing well, avoiding ambulance handover delays, and also the opening of the new children's assessment unit and bringing them into the division has been great to see. And then also an update on pharmacy and some of the shared decision making work. We talked about this 2 or 3 years ago, and based on some of the pilot work, to say let's accelerate this. And Daljit and others have been real advocates of making this work. So we've moved to now 16 councils across the organisation, and this one just gives an example of some of the things that they've been able to do in pharmacy. All of those councils actually demonstrate by empowering the front line, they will improve quality and usually reduce cost as well. And there are examples of that here. So just really pleased to be able to share those and to push that in the organisation, but also across the group. And then there's a further updated list of staff engagement visits with executives that are helping us to get closer to the front line as we move out of COVID. So that's my report, Chairman. Happy to take any questions.
Great, thank you, Glenn. And this morning, when we were talking about our people update, the focus on kindness and joy as behaviours and ways of being in the organisation were discussed by Gertie, and the work we've been doing on civility saves lives has been an important building block, but we won't talk about the staff survey because it's embargoed. So questions and perspectives, Julie?
Thanks very much, Chair, and thanks, Glenn. Just a couple of things. We had a really good presentation and discussion about inequalities and addressing those this morning. And your report talks about, locally, we talk about how wanting to address mental health as one of the key pillars. And your report refers to the fact that the delivery plan doesn't tackle care backlogs across mental health and community services. So I have one question about the implications of that. And then the second is around the cancer targets, which are set out, and 75% of urgently referred suspected cancer by March 24 could cause some concern. And I just wanted to link that to your earlier paragraph where you talk about clinical prioritisation and how that might work in terms of urgent cancer referrals.
Thanks, Julie. Glenn?
Okay, great question. So let's so firstly, the mental health services. I mean, we just clarifying that this recovery plan is only about the elective backlog. That doesn't mean that it isn't equally important to address backlogs in other services, and probably both the backlog and the increasing demand for mental health services is probably one of the most significant things that the NHS faces. So what I am also expecting to see in the spring is an update of the long-term plan for the NHS, which we've had a meeting with Amanda Pritchard and team last night. That's being worked on at the moment, and I will expect mental health to be one of the biggest priorities within that. So it's not deprioritising it, but this is just a plan to look at the elective backlog, and obviously links into the additional funding that's coming through the national insurance increase. The reason that the plan refers to cancer services as well as the elective recovery, though, is because both cancer services and elective recovery compete for theatre time and elective ward capacity time. And again, there was a desire to ensure that we continue to improve cancer access whilst dealing with the elective backlog, hence the need for us to have some milestones associated with both cancer and elective care. And what I would always say around the ambitions in the plan is these ambitions are supposed to be the minimum. And what I would expect us to be doing as an organisation is exceeding those targets, and proudly doing so. So these are the kind of milestones which we must be better than. But I think locally we've got an ambition to do better than that.
and it's probably worth clarifying for members of the public, Glenn, being at level 4 and the infection prevention and control measures we have put in place really for phase 1 of COVID, to what extent does that affect our capacity? And therefore the removal of them would obviously free up capacity.
Yeah, it's having an impact still in a couple of areas. Firstly, it has restricted our ability to use our capacity in a normal way. So we're still having to separately cohort COVID patients from non-COVID patients, and pathways into services and waiting rooms into outpatients and endoscopy areas. So that's limited the capacity. But one of the other things that I think we could move on now that it's also done is the protocols pre-operatively for patients. For example, for some elective admissions, the patients need to isolate for 3 days prior to admission. Now that was sensible with earlier waves, but now that we're dealing with a milder strain of COVID, I think the balance of risk has changed, and certainly the ability to pull a patient into an empty space on a list if they were available and get their operation done, treat their cancer, whatever it might be, it is certainly more beneficial than the associated risk. So I think it's those kind of areas. And I still think, you asked me this one earlier, Chairman, I think there's probably about a 5% impact in both of those areas, with not being able to fill spaces and also limiting our flexibility. So yeah, I think it's time, but we should always keep an eye on what's happening with new strains. It's time to reflect on the balance of risk.
Thank you, Glenn. And keeping things going, so we've got a lot to cover. Rebecca, and then we'll move on. Rebecca.
Thank you, Chair. Glenn, we know that workforce issues have been tricky for us, and it's something that's paramount to the board. In regards to Operation Ring Fence, what assurance are you taking in relation to the adequacy of our workforce to get that programme up and running and sustainable?
Yeah, we've gone through, and we'll talk about this when we look at the performance report. We've gone through a tricky time of staff absence. Actually, general sickness is not been abnormal. It's the impact of isolation of staff because of COVID. So that's restricted our capacity a little bit. Actually, though, our staff are incredibly keen to get back to doing what they joined the NHS to do. So Operation Ring Fence is really to contain urgent care in its footprint, with the specialist teams that manage urgent care, but to free up the elective capacity to do the elective work, which is what those teams are best at. So as well as a productivity gain through Operation Ring Fence, there's actually a safety gain, because the patients in the right beds with the right teams is the main reason why we've seen an improvement in our mortality and improvement in our safety generally as an organisation. So I think it's a virtuous thing to do for a number of reasons, and our staff will be very keen to get on with it.
Thanks, Glenn. Thanks, Rebecca. Okay, we'll move on then, and we've seen it a few times before, but it's for approval now, the draft finance and activity plan for next year, or now it's 4 weeks away next year. Glenn, Hack.
Thank you, Russell. Glenn's already given an overview of the planning guidance, so I wasn't going to go into that in any detail. The other key point to note is that we don't yet have all the information to actually construct the plan. For example, the system has got its revenue allocation, but we haven't agreed the split of that between the organisations. We don't have education income allocation, and we don't know what our specialised income allocation is either. And at the time of writing, not all the guidance have been published as well. So even now, some of the guidance is in draft. So it's quite a tricky planning round with quite a lot of unknowns. So what you've got is a draft plan presented here on the basis that we've got to have budgets in place before the 1st of April, and we need to do a draft plan submission in a couple of weeks' time on the 17th of March. So what I've tried to do is present here what we know, clearly set out the assumptions that we're applying based on what we know, and then set out what that plan looks like and give a progress update as to where we've actually got to. The basic approach, as Glenn said earlier on, it's about managing urgent and emergency demand as efficiently as we possibly can, and then to see and treat as many patients from our waiting list as we can, as quickly as we can. And he mentioned Operation Ring Fence, and also linked to that is improving productivity, particularly through our theatres and outpatients as well. So that's our basic strategy and approach. So regardless of what it says in the planning guidance, our strategy and approach is to see and treat as many patients of our waiting list as we possibly can. So the activity plans that you see within the paper have been constructed by the directorates on that basis. They have been worked up bottom up, and they're built on the demand and capacity work we've done previously. We still need to factor in productivity improvements into those plans. So we're confident that we can meet all the national targets around reducing waiting lists and waiting times as well. So based on the numbers there, you'll see that they look pretty good at the moment. That's before the productivity elements are factored in as well. On the money side, this is a bit trickier because there's more unknowns around the money. The key bit about the money actually is that money is going to become more important, or managing the money is certainly going to become more important going forwards. Over the last couple of years, pretty much we've had the funding made available to us to manage what we need to manage. Having said that, though, we've been still managing our money very tightly. So we've got a very large underlying deficit, but it hasn't deteriorated significantly over the last couple of years. So we're still in a relatively good position. So what you see in the paper is based on the assumptions set out in the paper, and what we know at the moment is a deficit of £2.9 million with a CPIP target of 8.4%, and that savings target is towards the top end of our range. But as I say, still quite a lot of unknowns, and those numbers might change. One of the key elements that we need to focus on is around our elective activity and opportunities to actually treat more patients. So we have, as Glenn said, put in a bid to increase our bed and theatre capacity, which will enable us to support the broader system as well as support Leicestershire as well, if that bid was approved. And in conjunction with that bid, there are also, and productivity improvements, there's opportunities for us to earn additional income. So one of the key points in the planning guidance is that even though most of our income will be blocked on elective activity, so that's planned care activities, so that's electives, day cases and outpatients, will be paid on a per patient basis based on a national tariff. So the more patients we can treat, the more we'll get paid. So there's an incentive there to treat as many patients as we can. So that's the key element that we're focusing on, and that will help our underlying financial position as well as doing the right thing for patients. So that would be a bit of a win-win. In terms of the capital plans, we've had 3-year capital allocations for the system, but we haven't yet agreed the allocation per organisation. But it is going to be really tight because we've got less capital than we've had previously. But there are some specific allocations around digital maturity and around the community diagnostic centres. Having said that, though, the allocation for the community diagnostic centres is significantly less than what the system asked for. So there's some quite challenging discussions going on about how we make those 3 diagnostic centres happen with significantly less money than we asked for. So there is still quite a lot of work to do on the capital, but the capital plan internally has been built up with the directorates, and each of the directorate bids was risk scored by the directorates and cross-referenced with the risk register, so that we make sure we're focusing on all the right things, and then it's been prioritised to the capital management group. So again, a very similar process and a robust process that we followed in previous years. So just to kind of round off, really, the key risk really is going to be around our workforce availability and our ability to drive productivity improvements. But that's also one of our key opportunities around driving those productivity improvements. So the recommendations set out in the report, which are basically around giving delegated authority to Russell, Glenn and myself to agree any significant changes to the plan before we submit the draft plan at the end in a couple of weeks, and for TMB to agree draft budgets before the 1st of April, and also put in there that we plan to have a 20% headroom on our CPIP target, because there's always some slippage in there as well. So I'll leave it there and take any questions.
Okay, great. Thanks, Mac. Can we quite quickly, rapidly go through the questions then? So in summary, roughly 200 million of turnover, deficit of around 3 million, and a CPIP of around 4%, which isn't trivial at the moment, but it's good change, and there's upside if we can drive the volume. Glenn?
Yeah, the CPIP is a challenge, but I think we are in a stronger position for delivering the elective activity, as Hack mentioned. And I think when I described the elective recovery plan earlier, one of the things that is clear, albeit draft guidance, as Hack says, is that individual organisations will be paid for the activity they do. It's not kind of affected by system level performance. So I'm confident that we can deliver a fair proportion of that CPIP through elective activity delivery, and that's why I'm kind of prepared to swallow a slightly bigger CPIP plan than we would otherwise.
Yeah, but we do need our tertiary partners to deliver on our shared service level agreements to see that throughput through. Anil? Okay, I can't hear.
You, Chair.
Yeah.
Thank you, Chair. Very quick question around CPIP, Huck. The 20% slippage is 20% of 8.4 million target, right?
So what we're saying is we'd plan for something like £10 million on the basis that 20% of that wouldn't get delivered, and we deliver the 8.4.
Okay, so 8.4 is after that 20%.
That's what we need to deliver, yeah.
So it's 10.4. And just to mention, Chair, I sat in on Finance and Performance Executive Subcommittee, and all the directorates provided detailed inputs to the service delivery plan. So quite comfortable with the way the business plan's been developed, bottoms up.
No, great, thank you. And just to remind members of the public that we have these monthly deep dives into each of the divisions called the Finance and Performance meetings, and that includes, it's run by executives, but includes non-executive oversight. Thank you, Neil. And Julie?
Yeah, thanks, Hack. I just wanted to be clear, just to clarify in my own mind, the impact and the risk associated with energy costs.
So at the moment, in terms of national funding, is based on normal levels of inflation. So that's what we've assumed at the moment. So that is inflation generally, I think, is a key risk here, because it's not just energy costs. It's inflation is running at quite high levels across the board, but we haven't currently been funded at anywhere near that level, and we are flagging that risk up the chain because it's going to be the same for every trust.
No, great, thank you. And finally, Glynis, and we'll move on. Glynis?
Thank you. Hack, it's just about the capital costs, because I know there's a lot of pressure and we've got a lot of developments we want to fund, and the system allocations haven't been decided. How is it going to be decided? I just wonder if you could quickly outline how they're going to decide the allocations.
Do you want to answer that, or do you want Glenn to answer that?
Does Glenn want to start off, and I want to chip in on that one?
Yeah, I'm happy to start off, and Hack, if you could agree with me, that would be really useful. So yes, so an allocation's going into system level, but there's now much more clarity, transparency around the formula that backs that model up. And there was a review carried out last year, which I was involved in, which is giving each ICS the steer that formula should almost be the default. So particularly because it gives the organisations with the assets the funding to replace their assets, and that's quite an important element of this, because a big component of the base capital allocation is simply maintaining our estate and our equipment. So I would expect that to be heavily steering how we allocate capital. But as you know, there will also be aspirations and needs and other things, requests of capital from partner organisations across the ICS, which we will have to negotiate our way through to see if we can move money between organisations to do things that are important for the system. So there will be a process for negotiation on this. I think there's a bit of trepidation around this because there isn't the money to do everything, and there are some big aspirations elsewhere in the ICS. So it's something I'm sure we'll come back to at board as those debates continue.
It's a genuine issue where you've got a PFI. Self-evidently, the PFI revenue costs pay for the maintenance of that PFI building or hospital. Where you don't have PFIs, you need to pay out of capital for any improvements. So that's a genuine issue. Okay, team, need to move this on because we've still got a lot of room to work to cover. So we need to approve this draft plan, albeit it's draft, but just to allow you to hard code it into the budgets at divisional level. So if you're not happy to approve this draft financial plan, please raise a digital hand. I can't see any digital hands being raised, so duly approved. Thank you, Hack, and keep us briefed as the numbers hopefully become a bit clearer. The Trust and Foundation Group annual objectives, Glenn?
Yeah, so we discussed these when we met in private last month, so that we could agree what they were to bring them formally to the board today. So I won't go through the detail, but what this report does also is identifies the engagement that's taken place with our staff around those themes and some of the feedback in that, which is really quite useful, and how we're setting out to ensure that all of our staff understand the objectives, and obviously also once approved, these objectives will feature in the objectives of individual exec directors and the people that report into them and cascade through the organisation. In previous years we've set out a separate list of things that we're doing at group level. What we decided to do this year is to set the objectives for each trust, but to identify the overlapping areas and then just strengthen our delivery by working together on them. So there's quite a few things in there that are common to all three trusts, and that's not surprising because the circumstances in which we operate. But for example, the elective recovery operation ring fence, that we will do that better by learning from all three organisations and coordinating the efforts. So the way that will work is every objective here will have a lead exec, and those lead execs will link into their counterparts on those things that are common across the group. And as you know, Chairman, we had a meeting of the group strategy committee last week. We also had with us our new associate group members, Worcester Acute, and I've shared these objectives subsequently with their chief exec, and they're looking at how they could work with us and strengthen the delivery further. So that's another good opportunity to improve and share. So we looked at these in draft form last time, so they're here for formal approval.
Thank you, Glenn. So we have seen these before. Any questions, colleagues? So I'll move just on because it's for approval. If you're not happy to approve, please raise a digital hand. Duly approved, thank you. So we'll then move on to the Estates Quarter 3 report. Patrick, we've obviously read it. What would you care to pull out?
I think the key thing is the Community Discharge Centre. That is now on schedule to be completed at the end of June, which I think is slightly later than we were hoping initially, but I think the report has mentioned in terms of just groundworks and actually supply chain issues, but we're confident we've now got the pipeline for the equipment, and we're very focused on then the labour side to actually get it all done and up and running. So I'm conscious, Catherine put a comment in the chat box around actually physically seeing it, but also conscious that we've started the enabling works for phase 2. So we're not holding back in terms of, obviously we've got to resolve the capital allocation issue, but I think that will be done. So we are moving ahead with the next phase as well. I would have mentioned, say, that the investment bid as well, but that's obviously Glenn's mentioned that. So that's in hand, say, for the 2 theatres and another ward, which will help us be more resilient and have the ability to do more elective work, which I think is really important.
Oh, great, thank you, Patrick. Any questions for Patrick on the Quarter 3 Estates report? Rebecca?
Quick comment, Patrick, really, given the visits that Ned's do around the piece, and estates is one of those areas, it would be remiss of us not to commend and to thank our estate staff for all the hard work that's going into supporting this plan. Thank you.
No, thank you, Rebecca.
Thank you.
Julie?
Just a couple of quick ones, please, Patrick. Is the risk associated with both the CDC or the Community Diagnostic Centre and Captain Tom Moore theatres, if they're delayed around our elective recovery targets, the impact there? And the second thing is, we heard this morning about our green plan aspirations, so the link between capital projects management and the green plan as well, please. Thanks.
Yep, I think our plan reflects, I suppose, our current thinking in terms of reality. We haven't baked in the extra capacity. We've said actually that's an opportunity, but we can hit our plan without. But I think, as Glenn said earlier, one of the upsides for us is the ability to provide patient care to our patients faster, but also then to have the opportunity to provide care to out of area patients that would otherwise be waiting longer. So it's quite a compelling, I would say it, I think, but well, I would say I'm objective as much as I can. I think the bid for us to have another 2 theatres and a ward is very compelling, because it does create that quite separate elective centre, but is still on an acute site. So we still have full availability of critical care capacity and other things, and combined with the community discharge centre. So I think it is a very, very good case.
Yes, thank you, Patrick. Thank you, Julie. And then finally, Neil, and then we'll move on.
Yeah, thanks. Obviously, Patrick, great work going on in its state, a lot of it happening. Any significant risks of slippage or any slippage, significant slippage that we should be aware of?
Not now. I think we've now got the CDC buttoned down. Obviously, it is getting a lot of attention from the team. It's not taken for granted that it will all happen, as you might expect. The mindset here is to just keep checking in and making sure that they are delivering against a project plan that we've agreed. So it's not taken for granted by any stretch.
I think that's great. Thank you, Neil. Okay, well, can you please pass on our thanks to the estates team, as Rebecca indicated, and keep us. Thank you, Patrick. And then just again, the quarterly update on sustainability. Jenny, anything you particularly like to put out?
Just to say that the quarterly update this time also gives assurance to the board that we have produced our green plan as required by trusts, and we discussed that in our development session today, and that will be published thereafter. So I pick up on that, but also that whilst we were developing that, we've also continued with our interim strategy on the key 10 focus areas, and the report outlines some of the key progress in relation to those focused areas. And then finally, I'd like to draw attention to the fact of the intention to really sort of take forward and create the visibility of our sustainability ambitions with our trust-wide campaign that we're taking forward in terms of really getting our teams involved with sustainability as an agenda to be embedded in everything that we do. And we're looking at that within our improvement programmes, and we're also looking at that within our service development planning, etc. And sort of thinking about from a anchor organisation and corporate social responsibility perspective what we can be doing through our sustainability ambitions and agenda to drive that agenda forward. The final thing I pull out from the report is that we did do a sort of self-assessment against the good governance framework for looking at key areas of assurance for boards around sustainability, so that we are really clear about the areas where we're really strong on reporting and areas where we can progress further. Those would be the things I'd want to pull out of the report, and thanks to Sean and others that helped compile the report today.
I thank you, Jenny, and it builds on the discussion, as we said earlier, on the Green Plan this morning. Any questions to Jenny? Okay, thank you, Jenny. So we'll then move on to the quality assurance part of our board meeting. And the first thing to cover is a report on safe nursing and midwifery staffing. Dowji, what would you care to pull out?
Yeah, thank you very much, Chair. So the first thing to say is that the report covers our January data. And as you'll see from the report, in January, we saw a marked increase of COVID-19 cases, both in the community and within the organisation, which then had a knock-on impact on our staff sickness, where we saw an increase of 177 whole-time equivalent staff having to isolate, and with another 89.26 who were tested positive and needed to be therefore isolated due to being positive. The impact this had on staffing levels was that it was obviously quite challenging, but we were able to ensure that the safety on the wards was maintained by moving our staff around so that not one area is carrying the greatest risk, use of NHSP and also on and off framework agencies, of which the report describes the governance measures we have in place around that. So coming to our vacancies then, for registered nurses and nursing associates, which doesn't include anyone band 8A upwards, the vacancy rate is currently sitting at around 11%, which is 64.25 whole-time equivalent, and 61.8 of 82 of those, which is around just under 15%, are at band 5. It's important to note that we will have done recruitment events, and these figures don't include those people that have not yet come into post. Going on to our healthcare assistants vacancies, this is a really important area because colleagues will be aware there's a national ambition to get to 0% for healthcare support workers, and our education team are doing a fabulous job in their recruitment. So the report says for January we've got 6.1%, which is equivalent to 19.28%. But I'm aware that they've had a very successful recruitment campaign currently. So next month, I hope to show you a marked reduction in that figure, which is excellent. We had 23 staffing datexes raised in January. All of those were assessed as no harm and as safe shifts. The report also shows some of those areas where our vacancies are above 20%, where there's focused work going on. And these areas, the staffing would have been adjusted across the hospital to support those areas and ensure that staffing was safe. Now just focusing on midwifery, the report demonstrates that we've got a vacancy of 8.36 whole-time equivalent registered midwives, and we have appointed, but some people have not commenced in post, and colleagues will be aware that sometimes people do then go and work elsewhere. In terms of midwifery healthcare support workers, it's a very, very small vacancy of 0.07%. We've seen another improvement, which is really good, in our midwife to birth rate ratio, which this month was 1:28, and we've continued to deliver one-to-one care in labour, again at 100%. We're, in terms of vacancies generally, we are proactively looking at the international recruitment route, and we've got a partnership with Swift to look at Strand C. And finally, just to make the board aware that in January we commenced our 6 monthly acuity reviews, so we will report that on in the future. But in addition to the acuity reviews on the wards, for the first time we've used the newly published CNC tool for ED and for CAU, so we'll be able to bring a picture on ED staffing and CAU staffing at the same time. Happy to take any questions.
Thank you, Daljeet. January, a very, very tough month for everyone. Questions and perspectives to Daljeet? Julie?
Thanks very much, Daljeet. As usual, a really full report. And I know this is fully discussed and scrutinised at QAC, but I think it would be remiss not to actually mention this report in the context of the Panorama programme that was aired last week around maternity services at SAF. And I know it's looked at in a great detail, and also we look at it in other areas as well. But I just wondered if you could just highlight the areas where we can take assurance that the same things aren't happening at George Eliot in terms of maternity services, but also, Daljeet, to how we give support to our midwives, given the continued focus around maternity nationally.
I think those are really important points, and actually, Julie, we had a very detailed discussion about that in the Quality Assurance Committee. So if I take the first point, which is obviously, which is around the midwifery vacancies, you can see that our vacancy is actually quite low. We generally do very well with recruiting staff. Last year, after our birth rate of our assessment of midwifery staffing. We put some more investment into our midwifery staffing, and we're recruiting into that. We report a whole range of data into the Quality Assurance Committee, which takes into consideration the support that women are getting, such as the care in labour, but also the outcomes of those pregnancies as well. We report RSIs, we report HSIB cases, and the report demonstrates that last month we didn't have any of those. And again, our dashboard reports into the LMNS. So we've got the scrutiny at the LMNS level as well, which is obviously at a much higher level. And then we've had the recent scrutiny around Ockenden from NHSE, which has actually demonstrated the great progress that we've made. The point about how staff are feeling and their well-being is a really important one, which we're really conscious of, Julie. So we are doing some proactive engagement to try and encourage staff to have a safe space to be able to talk about any concerns that they've got. In addition to that, I've spoken to the Associate Director of Midwifery that in anticipation of Ockenden 2 being released later this month, that we put together some workshops for our staff, that we go through the report together and we co-create and take a collective leadership approach to what actions we're going to take as a result of that, rather than writing the actions responses in isolation to that. And we've got some ambition to take that even further, which is involving our service users, involving the Maternity Voices Partnership, and indeed having those discussions wider at place, so that, you know, we are really ambitious about the quality and safety of maternity care for our local population, and that, you know, we really engage everybody in that journey and they can see that we're open and transparent about that.
Really great. Thank you for that very comprehensive answer, Daljit. Spot on question, Julie. And I think the 1 to 28 ratio is also quite assuring as well, which you didn't mention. David, is you'd like to add?
Yeah, I was just going to ask Daljit if she could say a few words about the reassurance that we've offered to nursing staff, in particular our senior nursing staff who've been working to deal with some of these sometimes difficult staffing situations.
Yeah, thank you, David. So we have, so I've set up weekly meetings with ward managers and with the matrons, and that includes maternity. It's a safe space, it's 50 minutes, and it's a place where people can just share what they're feeling, what they're worried about, where they don't think they're getting the right level of support. And we also talk about what's coming and what support they might think they need for that. In addition to that, we have issued a letter which just really describes in more detail the support that staff do have when they're making those difficult discussions, making those difficult decisions. But also it's about their professional support that they've got from their own professional organisations. But the key message there is, providing they are working within their professional guidelines, providing they are risk assessing and they're putting the patient first, you know, they have that indemnity from the organisation and that we're standing right by their side. So that letter has gone out twice now during the pandemic. In addition to that, we have increased the nursing huddles that we have. So we've gone from once a day to twice a day. And on those nursing huddles, the ward managers come along, the corporate members of the corporate nursing team are there, and we'll discuss every ward and we'll discuss any areas that staff are concerned. You know, because acuity can change throughout the whole of the day. You can have one patient that's admitted that actually needs extra nursing care. So we assess the acuity on a regular basis, and that meeting then gives us an opportunity to say, okay, if we've got one ward that's actually wasn't at risk this morning but is now, what do we need to do? And those conversations happen throughout the day.
Really great work, and you know, good feedback in the chat box as well. Colleagues, happy to move on? Okay, thank you, Daljit. So we're then on to but you haven't escaped, the Quality Governance Report on COVID-19. What would you care to pull out of this, Daljit?
Thank you very much, Chair. So I'm going to start off and then I'm going to hand over to my colleague Catherine to cover the HSMR and the incidents. So the key thing I really want to pull out of the Quality Governance Report, which we've already touched on, the first one is the ongoing challenges we are having around COVID. And we're starting to plan and think about, as we've talked about earlier, is how are we going to continue to deliver services, particularly as measures outside of the hospital are no longer in existence, and there's no testing. So that puts a big risk for us. So we've got to find a way of delivering safe services while still continuing to be able to give care to patients. So the key thing there is also around visiting, which I'll pick up in a moment. But if visiting changes, that adds an extra dimension of risk to us as well. So that's really, really important thing, which I, appeal to our public, is please, inside the hospital, we're continuing with face masks, we're continuing with social distancing, we're continuing with hand washing. I would ask you to do that to keep both our staff and our patients safe. In terms of falls, you'll see from the report, the majority of the falls that we had were no and low harm. We had one severe harm fall, but that was deemed unavoidable. In terms of pressure ulcers, we've had 0 pressure ulcers that have been confirmed as avoidable for grade 2, 3 and 4, again, which is a really good outcome of the quality of care that patients are receiving. Our complaints response rates, again, has remained at 100%. One of our key challenges has been around visiting, which I touched on earlier, and just acknowledging how distressing it must be for relatives and loved ones not to be able to come and see patients. So last week we launched a bit of a call to arms and a campaign, which resulted in 2 events facilitated by Jenny's team as a bit of a think space for staff to come up with ideas on how they might, what else could we do to improve communication with patients other than visiting. And this week we had that session with our ward managers and our matrons, which also went really well, with loads of ideas, I think, for Jenny and I to look through and to start to prioritise. I'm also pleased to say that this week we've launched a pilot to just open out our visiting a little bit more, which would have potentially allow for one visitor to visit a loved one during a set number of hours, and we'll be looking at how the infection control measures will work during that time. In addition to that, I am actually aware that nationally the visiting guidance is being reviewed, so we'll look at that and ensure that we're compliant with that when that's issued. And finally, I just want to really, from my perspective, say yet again how fabulous our volunteers are and what amazing job they do for us to keep, to support our staff, but also to keep our patients connected with their loved ones. And particularly, I want to point out the Help at Home Comfort Service, which is being run by volunteers, where our volunteers are calling patients who have been discharged to make sure that they're okay and there's nothing more that we can do for them. So I'll hand over to Catherine.
Just before you do, Delta, just picking up on a couple of those points, the volunteers calling patients and the work of volunteers generally is something we also do at Swift, and it's a small example of some of the benefits of the foundation group of identifying and sharing best practice at pace. But the other aspect is I am very conscious of the additional burden it places on our staff of not allowing visitors, that our staff are having to be more involved with patients and helping them to use phones or iPads or whatever to communicate with families. So really want to recognise the additional burden, which is often behind the scenes, but continuing to provide compassionate care when there aren't family members able to visit is another demand on our team. So thank you, and please pass on our thanks. Catherine, over to you.
Yeah, and just to pick up on that point, Russell, I think it's a huge burden as well on some of the families of our patients who are on some occasions writing to us to share their experiences of the difficulty and the anxiety that causes when you can't be with your loved one. So I really welcome the fact that Delta is piloting visiting on the wards at the moment, because I think there is a huge benefit to patients, to their loved ones, and also, as you say, to our staff who've been being that family member often at times. From the point of view of mortality, really pleasing that our mortality figures remain within the expected range. And the report just highlights the progress we're making towards the requirement to review community deaths from the 1st of April. Because of the challenges with Omicron, we're perhaps not quite as far forward as ideally we'd like to be, and we're starting to review all the deaths in the community will be a big step. But this month we will welcome our first medical examiner officer, and we're also seeking to recruit 2 GPs to train as medical examiners to work alongside us and help implement that review process with their colleagues as we take that on. And in terms of incidents, we continue to report, and you can see quite high levels of incident reporting there. I think with the changes that the government has recently announced around learning to live with COVID and those sorts of things, a lot of our incident reporting, we religiously report all of our incidents related to hospital-acquired infections. And I don't know whether that will change in the future, but I think that as the approach changes, that may well be something that the national teams will change in due course.
Okay, thank you very much, Catherine. Any questions to Catherine or Daljit? Julie?
I just wanted to ask about the tension of the relaxation outside the hospital, and then when it comes, people come into hospital. Has that resulted in incidents between patients and staff, which has led to unfortunate incidents in terms of behaviour?
I'm certainly aware, just whilst Daljit's reflecting, I'm certainly aware that some members of the public are confused by so-called Freedom Thursday, and then a loved one goes into hospital and they didn't realise they weren't able to visit. So I think there's definitely a level of confusion, but has it caused anything more than confusion, Daljit?
I would say that I think you're right, Russell. As a majority of our patients, and where we do have visitors for those patients in exceptional circumstances, are compliant and understand that. We do have a small number where it is a challenge and patients will refuse to wear masks, and some patients will, for example, want to leave the hospital to go outside and not wear a mask, and then they come back in. So in those circumstances, we do a risk assessment and we manage it the best way that we possibly can to ensure that we don't bring in any additional risk for our other patients. But they are small numbers, and we do a lot of work, and there's a lot of information that's gone out. Our comms department has done a fantastic job of putting information outside into the public, but also inside. We've got some posters at every bedside. We've got availabilities of masks and hand gel at bedside. So we're constantly looking at ways that we can keep reinforcing that. But I'm pleased to say, to small numbers. We've never had a situation where it's been very difficult to handle. It's been a respectful conversation.
And I'd just add to that, Julie, because since we're in a public board and a public forum, that whilst Omicron and COVID may have changed the benefits of the vast majority of the public being vaccinated, whilst an individual's risk outside of the hospital may be smaller than it was back in March 2020, we are still caring for very vulnerable groups of patients in the hospital, and therefore it's really important that we maintain the highest level of rigour around some of these practices in order to keep all of the patients we look after safe.
No, thank you, Catherine, and very important public health message there. Colleagues, happy to move on. So then got the standard Guardian of Safe Working Hours update. Catherine, anything you particularly want to put out?
Yes, so the report hopefully is fairly self-explanatory. There were 9 exception reports raised during the period, 7 in medicine and 2 in surgery. As you will see, the concerns have been managed initially in respiratory with a meeting around some safety concerns that were resolved. The other concerns related to working overtime, which was settled with payment for the overtime worked. I'd be happy to take any questions.
Thank you, Catherine. Questions or perspectives? Rebecca,
to offer a quick perspective, I'm a regular visitor to Junior Doctors Forum, and I'd like to give the board assurance on the open and constructive conversations that take place and the amount of support that's given by our consultant staff to resolving any concerns from our junior doctors. Thank you.
That's great. Thank you, Rebecca. And any other comments? Colleagues, happy to move on? We're running a bit late, but the integrate, move on to the performance assurance part of the report now. The integrated performance report, David.
Thanks, Russell. Yes, so continuing to experience quite a bit of challenge in terms of demand for our services, and still really dealing with the end of winter, and that plays out in the performance report that you've got in front of you. So that's a combination really of winter complicated by the intricacies of managing COVID-19, some outbreaks, and also our plans to get elective recovery back online, which are driving those pressures. But all credit to our operational, clinical and support teams working very, very hard across the hospital. Our performance is still relatively strong compared to the national picture, despite those challenging times. Our focus on discharge continues, and I'll say a little bit about that alongside Operation Ring Fence, which we've heard mentioned a number of times. And last week at our FPE meeting, so these are the Finance and Performance Executive meetings where our directorate teams come and spend a bit of time with the executive team talking about performance, and Anil and colleagues from the NED team joined some of those meetings. Very focused last week on wellbeing, checking in with the teams to make sure that they were okay. And then a focus on planning for the coming financial year, and we've heard the headlines from that earlier in the meeting. I'm not going to cover ground that we've already covered, so we've touched on mortality, and we've spent quite a bit of time on the quality governance agenda. So I'm going to focus in the interest of time on operational performance and take us straight to ED and 4 hours. Our performance in January there, just a little below 80%. So not where we would want it to be against the 95% standard, against the 4 hour clock. But actually, in terms of national performance in the upper quartile, pretty consistently, and actually more often than not in the upper decile of national performance. So strong, relatively speaking, but would always want to do better in that regard to move people quickly through our A&E department. Ambulance turnarounds are a clear focus for us in terms of national priorities. We had 30 vehicles during that period who waited longer than 1 hour to offload their patients. In most cases, that was minutes more than an hour. We are not an organisation that holds long waits. We're generally very swift in terms of offloading ambulances, but we have, in terms of improvement, using data to drive our improvement agenda, and identified that about 30% of ambulances that come to the hospital wait more than 30 minutes, and we think we can do better than that. So the team in ED are particularly focused on that. We've also, using the data, noticed that our performance tends to be worse at night. And yesterday, our A&E General Manager led a think session with colleagues to work out what we could do to improve our overnight performance and to start the day in better shape than we are currently starting it in performance terms. Flow across the hospital is a significant driver of ED performance, and discharge is a key focus for us as we aim to improve flow across the hospital. We are going to include going forward some data in our performance pack relating to discharges, and we've been spending some time over the last month refining the quality of data that we've got available to us. We now have a daily dashboard that's published to the executive team, and we're going to work out how we take that and summarise it into the IPR, so hopefully that'll be available for next month. We've also taken a significant number of steps to improve discharge processes. We've been working with ESIS, who are our national expert emergency care improvement team, and they're helping us to improve board round effectiveness and bringing discharges home earlier in the day, and Patrick is leading that work in partnership with them. Dalgit has agreed to be our discharge champion at board level. And we will be building the sort of softer side of discharge management into some of the work programs that we've already got built into our program of improvement work. We've undertaken a gap analysis against the Safer, Faster, Better standards and the National Discharge Task Force standards, and that will form the basis of our presentation into board next month when we come to spend a little bit more time on discharge. And outside of the hospital, still working very closely with partners. We're very focused on medically fit for discharge patients and not keeping patients in hospital for any longer than is absolutely necessary. Today we've got 53 patients in the hospital who could be somewhere else if there were packages of care, etc., available to support them. That's an improvement. That's reduced from 70 patients last week. We know there's some system work to do on that, and we've commissioned a review led by Zoe Mayhew, who is a senior member of Warwickshire County Council, who's going to be seconded for a year to help us improve the whole interface between hospital and out of hospital care. So looking at packages, discharge to assess, the way we commission those packages, and the way we recruit and support the workforce and that delivers packages of care. We think there's some real opportunities for us to work together with not only our public sector agencies, but also with the private sector to improve the offer there. So partnership very much at the heart of that. In terms of elective work, and remind again, the relationship between urgent and emergency care and elective work is key. Separating those two things and protecting our elective capacity, a real issue for us. We've undertaken a piece of work over the weekend to restart our trauma and orthopaedics joint work, and we managed to do that yesterday. So we did a bit of a restart to get out of Captain Tom surgical unit, where we did have some emergency surgical patients. Those patients have now been repatriated into the body of the hospital, which leaves Captain Sir Tom Moore unit available to look after our very planned elective work and our hyper-clean work around trauma and orthopaedics. Obviously, some big backlogs for us to clear, as we've talked about, and obviously also want to be very clear of an offer that we will make into the wider health system around backlog recovery. Doing pretty well actually in terms of reducing long waits, so 52 week is down to less than 200. Just to remind you, when we came out of the second wave of COVID, we had 1,200 patients waiting longer than 52 weeks. That's a more than 80% reduction, so that's good progress. And we had only 3 patients at the time of writing of this report at greater than 104 weeks, all of whom had dates before the end of February. So hopefully, and we'll need to validate this, those 3 patients have now been treated, and that greater than 104 weeks position is cleared, which again, relatively speaking, across the country is a good place to be. So positions us nicely, good strong foundations for what we've described in terms of our elective recovery strategy and Operation Ring Fence going forward. Diagnostic, some variability around diagnostic performance, but actually again, upper quartile performance when compared to the national positions, and 92.7 versus the 99% target for 6-week diagnostic investigations. And down in radiology yesterday, and they were pretty confident that within the unit they would get all modalities across the 99% threshold for the February month, and there may still be some risk to that target from other disciplines, but from a radiology and imaging perspective, they're in good shape, and they are the bulk of the work that passes through that pathway. Cancer performance still very challenging for us, but we've got some great people in our cancer team who are actively addressing weights and all over this, and one of the things I absolutely have confidence in is the grip on our cancer pathways. We can talk to each and every patient who's on a pathway and know exactly what the plan is with them. And in fact, we have seen some improvements during this reporting period against the 2-week wait and 62-day standards. And of course, the challenge now is for us to improve that and to sustain it going forward. So to do better, but to make sure that we don't go backwards. In terms of the report, I draw out the fact that stroke continues to be a major challenge for us. We still are struggling to get patients into stroke beds in a timely way and to keep them there for 90% of their time in hospital. So more work for us to do on that. It does relate to the broader flow conversation. So if we were creating more space and capacity in the hospital and doing better with flow, we would find that problem easier to solve. And then finally, just a comment on sickness. Running at 7%, which is a slight deterioration from 6.2% in the previous month, but nowhere near the peak of 12% that we experienced during the height of Omicron. Health and wellbeing a key focus in finance and performance executive meetings last week, as I've said, and continues to be a focus for us generally, with a key set of offers to both local and national interventions for those who need them. And Gertie may want to add to that. There's an awful lot of attention paid to this in terms of keeping and returning people at work following periods of sickness. So I'll stop there. Happy to take any questions or to direct them to the most appropriate of my executive colleagues.
A really great comprehensive overview. Thank you, David. Questions and perspectives, Glynis?
Thank you, Chair. David, you may want to direct this one to Daljit. But Daljit, with regard to safeguarding training compliance, I know we've done exceptionally well and maintained it through COVID, but quite a drop here on level 3 for safeguarding. Could you tell us a little bit about what's happening?
Yes, thank you very much for that, Glynis. So the change in that data has been a result of national intercollegiate guidance, which is best practice around safeguarding for level 3, is that we move to a different model, which involves us training people over a period of 3 years. So that then has had an impact on the overall figure. So I have sat down with the safeguarding team to have a look at that, and we are arranging a meeting with our education colleagues and with Gertie to see how we can figure out a process so that we can both ensure that we're delivering what's within the intercollegiate guidance, but also to ensure that, you know, there's some mitigation in that overall figure that we're reporting at the moment. Now, I've had a look at the numbers that are involved in there, and when we went through those figures, our trajectory was that within 6 months that should come back up, because it's not a huge amount of people that require level 3 training within the organisation.
Okay, thank you. Gertie, do you want to add anything to that?
Yes, I did, Chair. I think what I'd say, Glynis, is I feel more comfortable having gone through some of the detail with education colleagues and with Daljit Internet. This is that we have changed our method of reporting. I don't think the change we've done necessarily reflects the full guidance in the intercollegiate document, which talks about taught learning, but also reflective learning. And actually, what we've done is to try and measure the taught learning, but suggest it applies to both areas, and actually I don't think that's the case. So I think equally, once we've gone through the detail of the intercollegiate document between education and safeguarding and myself and Daljit, we will actually see that will recover itself almost quite quickly as well, because the intercollegiate document is really clear that we shouldn't recount the same learning 3 years running, and actually that's what's happened in terms of how we've been reporting it more recently. So we will see that going back up. It's simply we've used a sort of a rather dull tool to try and measure something that's much more complex.
Thank you. And Glenn.
So thanking David for the use of the term TRET, which is a good northeastern term. So on our elective performance, so well done for the position we are at on 104 weeks. The elective recovery plan sets out an ambition for the NHS to eradicate 52-week waits by the end of 23-24. We're clearly going to get there sooner, which is why we're talking about mutual aid. Are we having an internal stretch target as to when we will do that? Because I think that might then be a useful criteria beyond which we offer mutual aid to others, hold our 52-week wait position and then assist others. Do we have a feel? It may be a Patrick question. Do we have a feel for when we might get there on our own?
Patrick?
Not yet. No, I think as we conclude the planning cycle, then we can map out on the two conditions. One is no additional capacity, and the second is with additional capacity. So I think that's then, I suppose, and we will definitely set a more aspirational or a real ambition, not an aspirational ambition, sorry, choose my words better, to actually do more than the minimum.
Okay, let's come back to that. If you can give us an indication of that at the next board, that would be good, Patrick. Thank you. And Julie?
Can I just come back to stroke performance? We acknowledge that it's not where we want it to be, but could we have some assurance around the implications of that performance for the individuals? And also, can you just remind me, does that actually get reported as a DATEX incident, given that we're not meeting that target?
This has been the subject of many conversations at the Quality Assurance Committee, and I'll ask Glynis to come in a second, but we have tested and checked that because the patient isn't in a stroke bed, we are continuing to offer them the kind of service that they would expect to get in a stroke bed, with therapies and specialist clinical input. And Glynis, I don't know whether this is the moment where I bring you in and can invite you to just offer assurance or not from the QAC conversations.
Yeah, it's something we pick up regularly, Julie. And David's right, there's a whole suite of measures that we look at called SNAP data around stroke. This is just one of the measures that Quality Committee looks at. I would say that we've made significant improvements across all of the indicators for stroke, but this one will dip up and down depending on flow. And so we sought assurance that when we weren't able to put patients into stroke beds, they were still receiving all the key assessments and processes that they should have. And we have taken assurance at committee around that.
And Catherine, sorry, Russell, I think we're about to say the same thing.
Up to you.
I was just going to say, Catherine's just noting in the chat box that there's a further report on its way to QAC in April, looking at quality metrics using SNAP and GEH data. Yeah,
Catherine, it might just be worth circulating that to all of the NEGs, just for further assurance.
Yeah,
any other questions, colleagues? Otherwise, we'll move on to the finance report.
Did we cover? Was there two questions there, Julie? Did we cover both aspects?
No, I just wondered whether it resulted in a DATEX incident reporting if stroke wasn't meeting targets.
So I don't think we report individual patients not being in a stroke unit. We capture that data through SNAP, so it's visible to us that way. And I'm not sure that we've used the failure of the standard as a DATEX entry.
No, I don't think it's a DATEX issue. Do you know, Catherine?
Well, I'm hesitating to ask the question because I think we have captured this on DATEX in the past, but I'm not 100% sure. So I'll take an action to go away and clarify that and get back to you, Julie.
Okay, thank you. I didn't think it was a DATEX reportable incident, but I could be wrong.
I mean, Julie's right that sometimes we use that as a way of being able to assess that and also make sure that we're tracking the care of those patients. So. Yeah. But I'll go and check. But I'm absolutely convinced that we have checked through the Quality Assurance Committee about the fact that when we cannot get stroke patients to the stroke ward, our teams visit the stroke patients on the ward to provide the same care. Now, we know it's important to get patients to a stroke unit because of the studies that shows that this has a better outcome for patients, and we will not stop trying to sort this out. But it has been incredibly challenging, particularly in the month of January with outbreak on Felix Holt ward, in order to get patients there in a way that's safe and not exposing them to other infections.
Yeah. Dalgid, anything you want to add or happy to move on?
May I just add to that, Chair? And I think that was the point that Catherine made, is that they do get the assessments. I think the advantage of a stroke unit is the timeliness. And we have asked that question in Quality Committee. Do they get the timeliness of the assessment? And that's what's reflected in the SNAP. So we do take some assurance from that.
Okay. Dalgid, anything you'd like to add?
No, I think the incident bit for me, I think it would be reported as an incident if we weren't delivering the care that the patient should have had on the pathway. I think that's the key bit of it, rather than reporting everyone that doesn't get onto the right ward. The bit is that patient has therefore not had the required standards. It would be an expectation it would be reported.
Yeah, let's minute it and understand it, come back. Thank you. Okay, and then it's almost the end of the year, Hag, so just quickly on the finance report.
Yeah, I'll be very brief on the income and expenditure position. The key message really is that we're forecasting a break-even position with minimal risk. And on the capital side, similarly, we'd expect to come in within on the nose really in terms of our capital limit and deliver all the projects that the board has agreed. I'll take any questions.
Great, thank you. Any questions, Hag? Not really about our finance report, but Glenn, just brief us where we are on send sign, please, just in case any members of the public are aware, interested in that.
So Sensign has gone through an internal proposed management buyout, which Swift, who are full stakeholders of shareholders of, supported. We're still going through the process to conclude George Eliot and Wye Valley's position on that, but we hope that buyout is successful and their venture continues.
Okay, thank you, Glenn. Any other questions to Hag? Okie dokie. So Deepa, lovely to see you digitally this afternoon. The Freedom to Speak Up Guardians report, please.
Thank you, Chair. So the report I'll take as read, it covers the 3 months up to the 31st of January. During this period, we had 9 cases that came to the George Eliot Freedom to Speak Up team, 7 from workers, 2 classified as managers, and 4 of those came from the corporate directorate, 3 from women's and children. So they covered the significant proportion of the cases, which continues the trend that we saw in the previous quarter. 3 out of those 9 cases involved individuals seeking advice and support as opposed to raising specific concerns, and advice was given around direct conversation with line managers, escalation to senior management where needed, signposting to people and workforce teams, engaging in training where required, whether that's civility, cultural awareness, or other training opportunities. Conversations also took place with managers during that period to give advice on well-being conversations, engaging with staff compassionately where that was perceived as missing, and transparency and openness where that was raised as an issue as well. In terms of concerns, there was a wide variety of concerns there in the grid at page 3 of the report, but the themes that came out of the concerns really related to behaviours, patient and staff safety, policy and process, and concern relating to management and relationships. The actions taken in this period have been, as stated, discussions with line managers and escalating to senior management where needed, signposting to HR and union representation, also wellbeing and mental health support for staff where that's been required. We've arranged focus groups and one-to-one meetings. Dalgit alluded to this earlier in her report presentation, in areas where that's been needed, and also investigations have been commenced as well, and outcomes are awaited on some of those. Just a quick update on some deep dive areas that we've been engaged in. You may recall the sexual health team at Stratford was an area of concern in the previous report. Predominantly the issue in that area was around staffing levels and the impact that was having on patient and staff experience. Following escalation of those concerns, an external review has been commissioned. We're awaiting the outcome of that review, and it's expected, I believe, at the end of this month. In addition to that, the team were visited during the Appreciation Week by David, and that really did increase the confidence in the team in terms of their concerns being taken seriously, and also the trust's intentions as to really make improvements in that area following the external review. In addition, we've also put in place some monthly clinical support meetings in that area to give nursing staff access to senior level clinical support, which was needed. In midwifery, this was referred to by Dalgit earlier. We in the latter part of last year, arranged a listening event in this area. Unfortunately, that wasn't successful. There wasn't any uptake on those drop-in sessions that we arranged. So we're now looking at some focus groups for midwifery staff, and we'll be working with the Directorate and any oversight committee that we need to put in place to make sure any actions are implemented. And it's a similar situation in theatres. But in addition, in that area, we have provided a bespoke civility session for the anaesthetic consultants with the support of Catherine as well. And again, we'll be looking at focus groups to look at team culture and explore that further. On civility, we're continuing to roll out the basic awareness raising session. As stated in the report, we've reached over 700 staff across George Eliot and Swift. That number's probably nearer to 800 now. And we have increased the pool of facilitators by having a train the trainer session shortly before Christmas with people and workforce team, so that we can have a greater number of us delivering that training session. And then Sue and I plan to move on to look at putting an additional package of training together, looking at the second messenger technique, whereby we can really start to tackle incivility in the workplace. We're also working with Wye Valley to make sure that the civility offering is covered across the foundation group, and with the people development team to look at a possible bespoke civility session just for managers. The feedback from the civility sessions has been positive. People are asked to give us their key takeaways from the session, and the word cloud in the report gives you a summary of what people's thoughts were, and the most significant being that we're looking at people and their behaviours, and that's recognised, and the impact that that has on the workforce and the wider impact as well. One of the comments, the detailed comments that came through that I'll read is, staff should have confidence in challenging incivility. Just because some people behave in a certain way doesn't make it right. We all have a responsibility, no matter what position we hold, to address inappropriate behaviours in ourselves and others. And the overall rating given by 97% of respondents was 4 or 5 out of 5 in terms of that training. Just on the Speak Up Wellbeing and Inclusion ambassadors, that recruitment drive has continued. Since the last report, we have recruited 2 additional ambassadors within radiology and governance. We really hope to grow the ambassador network and recognise that there is work to do in terms of the diversity of that network, in terms of gender, all of the protected characteristics, shift patterns and so on. With the ambassadors, we've been able to arrange some training for mental health support from With Staff in Mind, and some poverty proofing training this year as well. The future objectives are bullet pointed within the report, so I won't go into those, just to mention on the policy that has been updated and reviewed. We're just waiting for feedback from colleagues before we forward that to policy committee for approval, and we'll be beginning to prepare the activities for Speak Up Month in October later this year. Happy to take any questions.
Really great overview there, Deepa. Are you enjoying the gig?
Yeah, I have to say that, don't I? Yes, I am, thank you. Everyone's made me feel very welcome.
Good, it was great. So questions and perspectives, Simone?
Thank you. Great update, Deepa. I just wondered what your perspective might be on the lack of uptake of the sessions that we had presented in maternity, given the scrutiny on maternity services.
Yeah, that's really interesting. There was quite a lot of work done prior to the session to make sure that staff were made aware of that session taking place, and of the confidentiality that would carry with it as well. It was located in the maternity building. Whether that was a deterrent, I'm not sure, in terms of people knowing then who might have dipped in and out of those sessions. So perhaps future sessions would need to maybe take place away from that environment. On the day itself, we did check that people were made aware that was taking place, and that was communicated by email, but posters and things which were advertised weren't seen on location, so that's something else to take away and learn for future events.
Okay, great. Thank you. It's a journey, Deepa. I think that's a reality, but
Yeah.
being sensitive to those sort of soft issues is obviously key. Gertie?
Thank you, Chair. It was just really to recognise and celebrate and commend Deepa and Sue's work. When we spend a lot of time talking about our Excel values and our behaviours, and that civility work and the breadth of reaching nearly 800 people is really significant. We know how key this is to having a really good experience every day and having great patient care. I think equally the work about the refresh of the ambassadors, the focus on greater inclusivity, and that those ambassadors, particularly around the poverty proofing training that they've had, I think we'll start to see a really, really good network coming out of that. So it was really, for me, just a really big thank you to Deepa and Sue. I think the work we've been doing has been fantastic. And I'll just finish with a final comment of a massive thank you to the charity, because the charity have funded Deepa's post initially, and we'd hoped to be making that substantive more moving forward, but we have been really blessed by the generosity of the charity. So thank you to Anna and colleagues as well.
Thanks, Gertie.
Money well spent. Jenny?
Yeah, thank you. So we were lucky enough to have the training in our team, and we thoroughly enjoyed it, engaged with it, and we are really looking forward to embedding that within that improvement methodology, because clearly behaviours and the sort of whole ethos and culture is absolutely the environment for improvement, and also just making the point about how all these things are coming together with our Excel values, with our patient experience strategy, with our patient safety strategy, and the civility, etc., and also the work streams around wellbeing for staff. I think it's a comprehensive package, and it's all building on that whole civility piece, because it's about the value of emotional connections for people, both for caring and for staff wellbeing and for patient delivery. And so well done, and we're absolutely looking forward to taking it forward into our improvement methodology. So thanks.
Thanks, Jenny. Glenn, did you want to add something to that?
Just seeing Jenny sat there in front of Fab Friday, I'm not sure whether we talked about that at Public Board. What would be a 2-minute elevator conversation about Fab Friday now it's started?
Yeah, thank you. So Fab Friday is what it says. It's fabulous stuff that's happening across the organisation and across place. The hashtag Fab can go in front of a number of things. It can be Fab appreciation, Fab feedback, Fab futures, Fab delivery, but it's really about celebrating all the fantastic stuff that's going on. It's also about Fab failures in terms of our reflective and learning practice. We had a great Fab Friday on the first week, but it's also about saying it's not just about Friday, it's creating that Friday feeling every day. It's about making that ability to feel that you're contributing and delivering and celebrating our fantastic people and fantastic partnerships and Fab transformation any day of the week. But get that Friday feeling, guys.
Great, thank you. Reminds me of the advert for Crunchies back in the day. No, it used to be the Friday crunchy feeling, showing my age. And Catherine, your hand was up, but it's gone. Missed your chance.
I've just written in the chat box, I'm conscious of time, but I really want to say a huge thank you to Deepa and Sue. The work that they're describing, and Jenny referenced it there, is so fundamental to our patient safety strategy. The quadrant on workforce safety is underpinned by our Excel values, our freedom to speak up culture, and the work that we've done with the consultants talking about civility has been interesting and really well received. But I think it's so important that every member of staff in the organisation treats other people with respect, and it's really great work to be involved with.
No, great. Thank you, Catherine. Well done, Deepa. Lovely to see you. Carry on enjoying things and doing what you're doing. You're doing great work. Thank you. Really appreciated. So then just sort of quickly pick up on some supporting information. The first is the QAC of the 28th of February and the report from the 31st of January. Glynis, anything you particularly like to emphasise?
Probably nothing really to add, because we picked up probably most of the things I would have raised in today's board meeting, which was just to say we had a very focused discussion on workforce capacity wellbeing, maternity areas and COVID. But I think we've probably covered most of it. Thank you, Chair.
Okay, thank you, Glynis. Any questions to Glynis? I guess also picks up on the 20th of December meeting as well, Glynis. Okay, so I think we're then on to any other business. Colleagues, please raise a digital hand if you've got any other business. Okay, can't see any hands raised. Thank you. But I do think we've got some questions from members of the public. Sarah?
Thanks, Russell. We've just had one from Natalie Mills, the Patient Forum Chair, saying that the government has lifted COVID-19 restrictions. Can the board advise the public of their strategy to allow open visiting again? And Daljeet's going to answer this one. Thank you.
Okay.
Thank you very much. And Natalie, thank you for your question. As you've heard on the meeting already, you know, we absolutely acknowledge the emotional impact and distress for families and loved ones and for patients, and when they can't be together at a time when they really need each other. So we are looking at, as I highlighted earlier, a range of methods in the interim to try and improve that communication. We have looked at the pilot for this week, which you've heard about as well, and hopefully, you know, by the end of this week we'll be able to roll that pilot out and allow some form of visiting for every single patient that's in the organisation. And then in addition to that, we're waiting for the national guidance to come out. I think the important thing is, because we need to make sure that we do it in a very safe and staged way, and that we are able to ensure that we continue to be able to deliver high standards of infection control as a result of doing that.
Okay, thank you, Daljeet. Natalie, did that answer your question as well as we were able to at the moment?
Yes, I think so. What I would say that the Patient Forum has been helping out with help at home comfort calls, and one thing that relatives are really telling us is how distressing it is that they can't visit patients and actually advocate for them and tell they want to how they were caring for a lot of their relatives, because this has been the over 75 age group, and how to improve that communication, I think. And I know that you have had the Think Space that David and I attended as well, which has been a good initiative, but it's just seeing that there's going to be light at the end of the tunnel, I think, for relatives.
Yeah,
I think we as a board, Natalie, just to gain some assurance, are very aware of the issue. My mother-in-law has been in hospital. She's 82 recently, and you know, we've had those practical issues. So, you know, both at a professional and a personal level, we are on it, but it's finding the right way through what balances the risk. And we are running late today, but any other questions from members of the public? Please raise a digital hand or come off mute. Okay, well then I'll draw the meeting to a close with thanks to everyone. Look forward to seeing you at the next meeting, which is on the 5th of April. And in the meantime, everyone take care, continue to take sensible precautions, and lovely to see you all. We as a board will have a 5-minute comfort break, and then we'll get back together in the confidential session. Shirley, I'm not sure if you're joining us for the confidential session. You're very welcome to. If you would like. So 5-minute comfort break, and I think we've got new dial-in details, haven't we?
We have. It'll be in your diaries for 4 o'clock, but you can connect earlier.
Okay, so see you in 5 minutes at 20 to 4. Thank you.
Thank you.